What if the key to healing your back or boosting your golf swing is learning to move like a baby again? Today I'm sitting down with Dr. Michael Rintala. He's one of the world's top dynamic neuromuscular stabilization instructors, or DNS. Mike is the secret weapon behind pro surfers and PGA golfers who need to stay in peak performance, but he's also just an incredibly down-to-earth guy with insights that can help you move and feel a lot better in everyday life. In this episode, we're going to talk about how a breathing exercise literally changed Mike's life. The crazy things that we've seen working with athletes, from ocean waves to the fairways, and why Mike always says your body has the answer. It's going to be a fun, informal chat between two colleagues, packed with practical tips you can use right away. So grab a coffee, settle in, and let's dive into movement with this journey with Dr. Michael Rintala. I promise you'll learn something new, just as you should every day. All right, Dr. Mike Rintala, welcome to the show, my man. Welcome to the show.
Thank you for having me.
Yeah, of course, man. We understand you're some hot stuff in the chiropractic sports medicine world, aside from living in California. Oh, sorry. I had to throw a Florida joke in there. All right.
Whatever.
Okay.
It's two against one, Mike. So just
I know. Oh, wait, Dave, we need the engineer back on that.
No, we're good.
Hey, all right. Well, hi, Dave. We became interested in you because of your world of rehabilitation, and especially after your own athletic injuries. You were a real hot shot in the tennis world, and you ended up breaking your back and then decided to go, well, we call it spondylolisthesis. You went to chiropractic college, and then you ended up in something called Dynamic Neuromuscular Stabilization, aka DNS. Now, that's what we want to talk about too, but we want to hear more about your history. But actually, first, why don't you give us a little bit of a understanding of DNS?
So DNS, Dynamic Neuromuscular Stabilization, it's based out of Prague School of Rehabilitation, and the developer or founder of these concepts and principles is Professor Pavel Kolaj. He's a pediatric physiotherapist, but also treats general population, and he works with the Czech Olympic teams, national soccer, hockey, tennis. So he sees general population, pediatrics, as well as high-level athletes in the Czech Republic, but also around the world. And with his knowledge, his experience, he has come up with the concepts and principles of dynamic neuromuscular stabilization. And one of the key components or concepts is that it's based off of developmental kinesiology, or what we call ontogenesis, which is the study of motor development after birth. And the developmental kinesiology, when you study it, when you understand it, you see the origins of movement and movement quality, synergy, coordination, and timing of our deep stabilizing system, which consists of diaphragm, pelvic floor, the entire abdominal wall, all the musculature running throughout the spine. And this is all controlled by the central nervous system. And during development, during ontogenesis and developmental kinesiology, the first year of life, this is the time where these inborn hardwired motor patterns are starting to express themselves. And it's a subcortical region of our central nervous system. And as the infant develops during this first year, you'll see certain developmental milestones. You mentioned a little bit about my history. I don't know about the hot shot with the tennis, but I tried, right? But my motivation for really going into where I am now was kind of selfish, right? I kind of fell apart like in college and didn't make sense to me, right? I was training hard and what I thought doing all the right things, but the wheels kind of came off. And from that point on, it was like, okay, how do I fix me? And that kind of like up to that point, I always had being an athlete, not just, I focused on tennis, but when I was younger, played all the different sports. So my idea was I was always on the track of going into athletic training, being an ATC. I liked that. I spent enough time in the training rooms. I liked that environment. I liked what they were doing. But once I fell apart, I kind of changed the track to like, okay, how do I address what's happening to me? And that was kind of the impetus to go to chiropractic school, because I saw with chiropractic, I could integrate PT, ATC, and I'd have the manual skills that I wanted. And all these things with my own experience with the spondylolisthesis and the fracture, the stress fracture in the low back, not any one thing was the answer, but I saw the combination of things move me towards where I wanted to be. And then it wasn't till chiropractic school, probably like a year and a half in, when we had a rehabilitation course, and I got introduced to Prague School of Rehabilitation. And at that time, we were learning about Professor Yanda, Carl Levitt, which are neurologists and physiotherapists. And when I saw that, I'm like, okay, it was like a year and a half into school. I'm like, oh, finally something makes sense, right? Or at least it made sense to me. And so that kind of put me on that journey of exploring what's now called DNS. And it wasn't until, once I got introduced to those concepts and principles, learned as much as I can, I started implementing them as best I could on myself, combining chiropractic, combining soft tissue work. And then it was probably a few years out of chiropractic school, saved up enough money. I went over to Prague School of Rehabilitation and started learning from them. And at that time, Yanda and Levitt were still who was known from Prague School of Rehabilitation. And on that first trip around 2003, that's when I got introduced to Professor Kolaj and saw how he was thinking. He was talking about developmental kinesiology and infants and relation to movement quality. And that was another thing that talked to me, right? And it's just been continuous from there. I don't know if I'm going on too much, but that's kind of the progression.
You're fine. I actually wanted to ask you that. Also, be aware that we do have a lot of doctors that are that listen to and view the show, but there's also lay people, and I wanted to mention that in a more practical perspective, you've often referred to this as basically relearning how to move like a baby, and the only thing that I can relate to is we've heard so much about cross crawl, and if you miss that, you got people back on the floor relearning how to cross crawl. What else would be a practical application to the patient? So your explanation is beautiful. People probably want to understand how it would pertain to them.
Right. So if you look at an infant and you observe how they learn to move, all that is their central nervous system maturing and expressing these motor patterns, but also they're exploring their environment. They have motivation to reach for the toy, to get up to a higher position. And as that central nervous system is expressing itself, and they have an ideal environment to explore points of support and move to these objects or things where they want to move to, that integration helps them get to those higher, more unstable positions. And it's not that we just want to move like the baby. It's not just crawling. It's not just working the cross crawl patterns, but it's the nuance of how you're supporting while you're doing that, right? Hand support, knee support, foot support, but also the external cues or the motivations to enhance that movement. A baby has different proportions, body proportions in us. It has different mobility, but the point is that we still have the same. The central nervous system still has a potential to express those patterns. So if we can use those developmental positions, hands and knees, squatting, lunging, half kneeling, to wake up those patterns. And as an adult, again, we have different limb proportions, different mobility, and wherever you are with your mobility or your ply, the suppleness of the musculature, you can still tap into these inborn patterns to help improve your quality or your coordination of how you stabilize, which will then help with your movement efficiency. The thing that will affect that nice expression of ideal movement and stabilization when we're younger is we sit too much, so postural habituation, we do repetitive movements, we get hurt. Usually we're looking at all three of those things affect that inborn motor program that wants to express itself. And when that happens, we start to use kind of compensation patterns. And our bodies and our brains are designed to do that. That's how we serve. It's like a survival thing, right? So if a dinosaur, I know this is the wrong context, but if I'm being chased by a dinosaur and my legs hurt, my brain's going to find some way to get out of there. However, I'm going to move. So if these other things affect that quality of how we're moving, then we're going to use what we call a high threshold or compensation pattern to create the movements. That's okay temporarily, but if that becomes your go-to pattern over and over, then we see wear and tear. You can take the spine, for example. We'll see wear and tear in the transitional areas throughout the spine. Lumbar region, thoracic lumbar, cervical thoracic. All the places we'll see the disc degeneration, facet hypertrophy, all the areas where we get wear and tear throughout the back. That then radiates to, can be elbow, shoulder, and knee. So you want to address the areas where you have inflammation or degeneration or pain. But where DNS comes in, it's looking at, okay, what's the underlying story of how that occurred? Was it traumatic, like a sport injury or something else? Or was it repetitive movements along with compensatory patterns that created the wear and tear, the pain? And we want to address both to help our patients, achieve their goals, whatever that may be.
Hey, Mike, I got to ask something. So, like Spencer is, and congratulations, Spencer, he's a new grandfather. So he has a new little baby. And so when we're seeing these little babies, what inspired you to look at this little baby or to seek more care from this, in Czech Republic? I mean, the only time we see adults acting like a baby is when they had a little too much to drink and they're laying on the ground.
Right.
Right. So, so a lot of time they're flopping around and they can't even roll over. And so then, and then you have these athletes that get hurt, or these older people, and they walk all hunched over, they walk bent. What made you start looking at this concept of looking at pediatrics and equating it to adults?
With pediatrics, again, with a healthy development of the central nervous system, you'll see that ideal kind of pure expression of coordination and timing of all the musculature as you're moving. And this is what Professor Kolage, working with pediatrics, with athletes and general population, that's what he started to put together and observe. So knowing or observing ideal movement, ideal position, let's say of the shoulder girdle, which then provides ideal position of this is your humerus into the glenoid. Observing that, you can use that knowledge and observation to assess us as adults or adolescents or whoever it may be, and you can see the efficiency of their nervous system to create this ideal stability and efficient movement patterns.
Mike, let me ask you. Again, I want to make this as practical as possible too, and that is, if a patient comes into you with a traumatic injury or an injury induced by a traumatic experience, or somebody comes in with something that's gone on as a repetitive micro trauma and they're compensating, because athletes are the best compensators of all, So when you approach that, we're in essence peeling back the skin of the onion to find the core of what caused the injury, correct? Or
Yeah.
to some degree? All right. And then you apply principles once you find, like, what would be an example? Let's use you and your spondylolisthesis, which is a fracture. Was that L5, L4? Was that where you experienced your spondylo?
Yeah, L4, L5.
L4, L5 common area.
Yeah.
And what did you do? What specifically, how did they figure out what the cause was from that? And how did they manage you? And, specifically, how did they manage you?
Yeah. So initially, as far as, it happened in college. Initially going, the orthopedist and the trainers, eventually with imaging, they saw the fracture, the stress fracture. And the big component there initially is, right, calm things down. And, and there's lots of different things they could do to help calm that down. But if you don't, again, address the movement pattern that created in the first place, it's just going to keep coming back and become chronic. And that was my thing. I couldn't get back to, playing on the team, right, or doing much at all because of the pain. So initially, if I see somebody or with me, it's like, okay, how do we calm things down? And again, different modalities, manual methods, medication, all that. You can utilize all that to try to calm down the inflammation. The big thing as far as the approach with prog school is there's certain assessments. Like, we take people through a whole sequence of different movements and watching the movement, palpating, touching people, feeling the tissue quality, palpating and feeling the mobility through the thoracic spine, through assessing the hip, etc. Taking that, looking at the soft tissues, so fascia and muscles, looking at the quality of movement and the joint structures. But then third, the big one, again with DNS, is what's the movement strategy? What's the stabilization strategy that they're using? Is it the efficient strategy where there's nice coordination and timing and nice stabilization? Because when you have that, it actually facilitates an unloading in the transitional areas throughout the spine. So,
hey, Mike, what were your red flags?
As far as
like your movement, what did they see on you that was causing the stress to your L405?
So a huge propensity to overutilize the extensors in my low back and hip flexors. And for me, lack of mobility in my thoracic spine, my mid back and my rib cage. And, looking back, if I look at pictures or videos, I have, what we call a kyphosis, or where, I tended to be hunched over. And you see this a lot with just, people who are sitting a lot. And so looking back, with that pattern leading up to the fracture in my back, I had a lot of tendinoses, impingement type syndromes. I had a lot of ankle sprains, various injuries, all of this affecting my quality of movement, and eventually, leading up to that overload through the back and the stress fracture. So that was the big component, the lack of mobility in certain areas, and then the overuse of certain musculature and the underuse of other musculature. Like the synergy wasn't there, the timing wasn't there. So something paid the price. And for me, that was my low back.
There's something to be said about, we're all three seasoned chiropractors. We've been doing it for a long time, studying biomechanics and movement. And I thought it was very fascinating that a lot of injuries that do come in, and you highlighted it for a moment, that the thoracic spine, probably one of the most neglected areas, is so rigid on most people.
Yes.
That most physicians, and I mean this in general, medical, not exclusively medical, but also come in with a neck or a low back, and that's all they treat. And I'm seeing more now that I've become aware over the years. The thoracic spine is so damn tight,
Right.
and
Yes. Right.
there's lack of movement with rotational. Right, Terry? You see that too?
Hey, Mike, on that, I've been focusing lately, probably the last 5 years. I don't even look at necks and backs anymore. I look at ankles, hips, and thoracic spine.
Yeah.
And
Yeah.
everybody pounds on necks and low backs. I go, well, those have to be stable. Yet the thoracic spine, the hip, and the ankle have to be mobile. Why are we looking at the things? Why are we trying to pound on things that are supposed to be stable and making them unstable? We should be focusing on the stuff that's that's locked up, that's supposed to be mobile.
Because that's what they taught us. That's what they taught us in chiropractic college,
Right,
30 and 40 years ago.
Right, bang, bang, bang.
Yeah.
And so when the chicken and the egg, since I just brought up ankle, hip, and thoracic spine. When you see yours, you were locked up in the mid back, your rib cage, your hips. Where do you start? Do you start at the hips? You don't want to throw all of it at once. What's your thought process and protocol?
Right. So one thing, after I assess and I see the pattern, right, and then assess the soft tissues and joint structure, one, with that assessment, if, let's say, the thoracic cage mobility is compromised, or hip or ankle, I want to address initially, the soft tissue or fascia, and then also joint function, right? Because there may be this underlying central nervous system pattern, compensation pattern, and I can, give them exercises and give them different cues to try to facilitate better activity. But if they're running into joint restriction or soft tissue restriction, it's just going to push them back into the compensation. So usually I start with, soft tissue, and I use various techniques. Then I'll go to joint function, and again, various techniques. And then once we get better mobility, better pliability of the soft tissues, then I'll start to facilitate or help them facilitate more efficient deep stabilization activity. And
hey, Mike, I'm going to interrupt you for 1 second, because this is the direction I want to go. We've heard so many different topics about breathing, and I know that's where you're going with diaphragmatic breathing. And we've heard, put your thumbs in your rib cage and push out, diaphragmatic breathing, chest breathing. There's so many different concepts of how to breathe correctly. So I'm really interested to see why you believe in diaphragmatic breathing when there's so many other experts that talk about breath holds and different stuff and different ways of breathing.
Yeah.
There's a bunch. So I thank you for going this direction,
Yeah.
and I want to just preface it with why diaphragmatic breathing is more important than some of these other techniques.
Right. So yeah, various techniques. You got Wim Hof, you got yoga, pranayama, various ways to activate the diaphragm. Right. What DNS is talking about, what I'm talking about is, again, going back to development. Once the central nervous system starts expressing these patterns, you see the activity of the diaphragm change. Up to 3 months, the central nervous system's immature. And if you look at the infant, everything, the breathing is, the chest position is in an inspiratory position. There's no ability to create the stabilization through the trunk and the pelvis. So if the infant moves, the whole body's moving. If it breathes, you see the chest moving up towards the neck and shoulders. Once the central nervous system kicks in or expresses these more ideal patterns, you see a change in respiration. The diaphragm starts to be able to contract, drop. You see the spreading of the thoracic cage, like the whole thoracic cage, instead of the accessory breathing muscles, the muscles in your neck and your shoulder, lifting the chest to try to create the breath. So what we're talking about is functional, the function of the diaphragm, which has to coordinate between breathing and stabilizing.
Because we see, as docs, we'll see these guys come in, and girls, and their traps are huge, their shoulders are huge, and they take their shirt off or whatever, and they have no lower lat, and they come in presenting with headaches and mid back pain. Yet everybody thinks they look like they're bodybuilders because their necks and their traps are gnarly and all that, and they like, and you try to adjust their mid back and you can't, and you're like, right. And every chiropractor, every physical therapist just pounds their neck, works their neck. So what you're saying is, when you see somebody present themselves with large traps, large scalenes, large neck muscles, probably one of the biggest things is their diaphragm's not really working right. Their neck breathing, and we should probably focus on breathing techniques and right. Is that what I'm getting?
Yeah. So those patients, right, you can do tissue work, you can try to mobilize, but if that's the pattern, you'll see upper ribs are fixed, right? Thoracic spine, you're not getting the expansion of the thoracic spine, so there's an adaptation of the fascia and the musculature, and then that affects the mobility through the thoracic spine. If you can't move through the thoracic spine, you're going to overload, cervical thoracic area or lumbar sacral. So, you'll see that patient, and one, you can usually just tell, right? Like, you look at the resting tone of the musculature, and they're just sitting there and everything's hypertonic. And then you palpate it and you're like, oof. And then especially you palpate the scalenes and it lights up, some referral patterns. And that's all part of the assessment of, like, these guys are working way too much. So, you can try to adjust and everything. And if you do, that's great. And tissue work, great. They may get some temporary relief. But if they're going right back to that pattern, it's harder to, again, move them to where they want to get to. The function of the diaphragm, which really is a mirror of the function of the central nervous system, is kind of the huge component here. You have Wim Hof, yoga breathing, again, all these different methods, and those can be utilized for different things, right? Calming things down, hyping things up, getting ready for performance. But we're trying to focus, and that also, all those different breathing methods create a nice awareness of the diaphragm. But what we like to see is, as far as with DNS, is, okay, that's great, but I want to see nice function. And I want to see integration and synergy of not only the neck and shoulder musculature, but the trunk and pelvis. And when you see that, again, you'll usually, if you look at the top athletes, one, they're great at compensating. They have really good, what we call cortical function, right? And that's one of the reasons they are how good they are. When you look at the athletes that kind of rise to the top, and you watch them move, you see this fluidity, right? It's almost like this effortlessness. And when I see that, I'm like, okay, they have good, that what we look for with the expression of the central nervous system. They have good cortical function, so they can input their environment and output the activities. And also with those athletes, you'll see longevity of career, right? They may get injured, but they recover quickly. And their overall career tends to be longer. There's plenty of athletes that still do well, but may rely more on strength and speed. But then you'll see those athletes more frequent injuries and harder times of recovering, and then maybe shorter span as far as career. So that's just kind of like something that you can think about with the history, or just an observation you can make looking again at the what we call dynamic neuromuscular stabilization. Yeah.
I was going to ask about remapping the brain, and you got somebody that comes in, they injured their ACL, they've been limping and putting pressure on one. Those are obvious things, and then you do some proprioceptive training or balance training for the layperson that wants to know what that means. But what about? I mean, you're going deep into areas that they're changing their biomechanics. It could be thoracic, but then they come in with it. They had a shoulder injury, and then their big toe hurts, or I mean, you're unraveling a lot of stuff. How in the world are you remapping the brain after they've been doing that for years?
Right. So it's a process, and a lot of the timeline of that process depends on their overall body awareness, right? So you can have, let's say I'm working with an athlete. Usually they're going to have good spatial awareness, good body awareness. And so as I'm working with them and helping them facilitate this pattern, it's usually going to be a quicker progression. You have some people with poor body awareness. I know that, okay, it's going to be a little bit more work on my part, manually positioning to help wake up their central nervous system. With athletes, when you're integrating these things, I'm not talking depending on the athlete, I don't talk about their specific technique. As if a pitcher, a golfer, leave that to the coaches. I'm just focusing on that quality of stabilization and that quality of movement throughout the joint structures. And as you do that, for example, let's say my runners, my swimmers, my bikers, for example, I'm not talking about their training. I'll leave that to the coach and again to the trainer. But if I improve the efficiency, what tends to happen, their times get better without them feeling like they're putting out more effort.
I got a quick question. What if a patient, like many of them, come in and there is no chance to improve a certain range of motion because so much scar tissue or injury is, and their movement pattern is screwed to begin with, and you're using a model of what good movement, especially in a baby, would look like without any restrictions. What do you do in a situation like that?
So, everyone's going to have different potential for improvement, and especially in our older population, right? We have degenerative changes. We have thoracic cage. Thoracic spine could be fused to some extent. Post-surgical fusions. Even with the structural issues, if you can still tap into more efficient expression of that coordination of respiration and stabilization with the diaphragm, you're going to help them improve as much as they can, right? You're going to improve the overall situation. So some patients, yeah, everybody wants to move how they were when they were 18, right? They want to, and that's why we see a lot of people, their 40s and 50s are trying to do what they did when they were 18. And part of it is like, okay, explaining the situation, explaining what you're seeing, and then talking about what the goals are. Usually one, pain-free so they can get back to activity. But if I can help them as much as possible, creating the ideal stability and the coordination of respiration and stabilization function, the diaphragm, then they can manage things better. So you can have an 80-year-old, maybe you just improve their breathing function. That's huge for them, right? Maybe it stops some headaches, or you get a little bit better stability, and they're loading less through their lower extremity. So there's limits again. It's not a miracle thing. It's giving them things in those cases to manage what they're dealing with.
Terry, my question will be quick, but your answer may be lengthy. So I just need to understand when we've got this thing called functional movements, FMS, and there's a series of movements that that a patient does, and there's a standard scale that they are graded by. And then there's Yanda's work and Kapanji and all that, and biomechanics, and let's see how you sit up. When a patient comes in, whether they got a knee problem, or they're 80 years old, or they're 17 years old, is there a set criteria of tests that you do, or do you modify those? Like if a person comes in with a shoulder injury, we do a shoulder exam or a knee exam.
Yeah. So the DNS assessments, there's like 12 different movements that we look at, also breathing and postural function of the diaphragm. And that I'll do that, and not all, doesn't have to be all 12. Usually you can take, depending on the complaint, you can do like 2 or 3 assessments, and you'll see what's happening as far as the movement.
Mike, let me ask you. Most people have crappy posture, and they ask us all the time, especially, the whole iPhone thing and the, sitting on the computer. Let me also let the audience know that you're only one of 18 certified international instructors in the Dynamic Neuromuscular Stabilization from that school in Prague, which is very honorable. So with that said, and all your super intelligence in that area, give us one activity or some activity that could be really practically applied to everyday stuff for a person that has shit posture. And they ask us all the time. Is that fair? Is that a fair question?
Sure.
All right.
So the probably the number one go-to would be on breathing and paying attention to your breathing pattern. And I don't know if you want, I could demo something.
Do it, man.
Sure.
Yeah, we love that.
Okay. So, and I don't know if people are like listening or
both. One or two. They can go to YouTube and watch.
Yeah. So if they're watching, and I'll do my best to describe.
Sure, bud.
Right. So if you can be seated, you can be standing, you can be laying down. But if you take your hands,
if you want, you could back up and.
Yeah. So
that'd be fine too.
Yeah. Okay. So if I'm seated.
Oh, you're sitting on a therapy ball. Look at that. Yeah. All right.
I'm stabilizing. I'm uprighting. So if you just take your hands and you put them, you have your hip bones, right? The ilium. So it's the hands are on your sides, just above your hip bones, your ilium.
Yeah.
And below the ribs.
Oh, I feel like a runway model. Okay.
Yeah.
All right.
And your fingers will be in the kind of the lateral aspect of your abdominal wall. Your thumbs will be in the kind of the back area of the abdominal wall. The abdominal wall wraps all the way around. So if I have my fingers in the front, my thumbs in the back, and then I squeeze my hands together. Now, just in this position, if you can, take like a 2 to 3 second breath in through your nose, and then 2 to 3 seconds out. Now, ideally, if that diaphragm is functioning nicely, it's going to drop and spread, and the lower ribs will spread, and you'll feel with your hands, you'll feel your thumbs and fingers spreading apart and your hands spreading apart. Oftentimes, if that ideal pattern isn't there, instead of the feeling in the hands, you'll feel the chest and shoulder rise up towards the head. Okay?
Nice.
So just a simple thing, just feeling, one, what you're doing. And if your pattern is bringing your breath up into your neck and shoulders, what I want you to do is, as you breathe in, have the intention of breathing down towards the chair or down towards the pelvic floor. And you want to feel, try to actively feel the expansion of the thumb and the fingers as you take the breath in. And so that's like a combination of assessment, but then also practice. And then the second thing that you can do is, now, if you give yourself a hug and you put your fingers in the lower rib spaces, so you give yourself a hug, lower rib spaces, and then let the shoulders relax. Now you're going to do the same thing. This time you want the intention of the breath moving down towards the chair. And also, as we breathe in, we should feel our fingers spreading apart. We should feel those rib spaces spreading apart. So the thing to take note of, is that happening? Or does that start to happen and then you feel the neck and shoulder musculature taking over? If we're just sitting here, we should be all diaphragm, right? So one, you can see where you're at with your breathing strategy, but you can also catch yourself if you're coming up into the neck and shoulders too much. And if you do maybe 3 to 5 breaths with that intention of getting that nice active, a nice spreading of the lower rib cage, the nice spreading of the abdominal wall, then you can start practicing that. If you can feel it, you can reproduce it, and that it's a psychomotor skill. It's like learning how to tie a shoe. At first, you got to really concentrate. You may get it. You may make a mistake and use the compensation. But if you're consistent, you practice, that'll start to get easier. And as that gets easier, you're reinforcing the pattern, and eventually that can integrate more subcortically. It can wake up those patterns. And then when you're not thinking about these things, instead of everything coming up to the neck and shoulders, now you're facilitating this pattern. It's just like, if you learn how to golf or surf or, pick your sport. At first, you're kind of flailing around, you're using too much of everything. But as you get it, you're not thinking about that stuff. You're just performing.
Are you, as the practitioner, now a patient comes in, are you doing that test on them? If they, okay, cool. Because that's what I was imagining, that they might not, on that first visit, that might be a cool exam part. So thanks.
Yeah. The biggest thing is, once they realize what they're doing, the usual response is like, why has nobody told me this? Right. And especially I see a lot of people, and I get a lot of pain medicine docs sending me their chronic pain patients. Right. And what I just described, probably like the number one finding is this discoordination. And the thing is too, if you normalize the respiration, the stabilization starts to almost kick in automatically. So that's like probably the number one go-to is the breath. And people have the right idea, okay, yogic breathing, Wim Hof, again, different methods. And again, different methods for different purposes. But what I'd like to see is those functional, with the functional activity of the diaphragm. In my opinion, with DNS, it's not don't do that, do this. It's integrate this to help enhance the good work you're already doing, because a lot of these things you're helping people, but how do we enhance that, right? How do we enhance the effectiveness of everything else that we're doing, whether it's manual techniques, whether it's training, whatever the integration. And that's the big thing for me. Once I saw it and I got an understanding of this, it was like, all right, I saw the potential of being able to, again, enhance all the other methods I was utilizing. So, yeah.
Dr. Mike, we're entering our favorite part of our program as we wrap up. It's the rapid fire questions. I think it's going to be a real challenge for you since but these are simple, easy to answer questions. Well, maybe not, but there's 5 of them. And if you're ready, let's live the rapid fire. You ready?
I need to put my glasses on for this?
No, you might want to keep them off. You might want to put in hearing aids. So no.
Yeah.
All right. Question number 1. If DNS could fix one celebrity's posture, who would you choose and why?
Oh, man, I thought these were going to be easy.
Oh, hell no.
All right. So I know okay, let's say, who's that? The actor who plays Thor. Hemsworth. Yeah. So I know he's had low back issue, right? Hemsworth. Yeah.
Nice, Dave.
So obviously super strong guy, right?
Yeah.
But I know just from reading he's had struggles with low back, and I think actually in Australia he may work with a DNS practitioner. But
nice.
So something like that.
Yeah.
Where you see this, athlete or celebrity in great shape, but they have pain. So I would add that component to whatever his training is as he gets ready for those roles, which I love. I love Marvel. I love I love Thor. Right.
All right.
So so that
very good. Very good. Question number 2 now. I hope you're ready for this one. This is going to be a tough one. You're on a holiday. You have one day and time for one activity, I should say. The golf course is the perfect condition. Nobody is out there, but it's also next to one of the best surf breaks in the world, and it's going off. Perfect shape, size, with no one in the water. Which
I'm going surfing.
You just made Dr. Terry's day. Okay. Very good. Very good. That was easy, wasn't it? All right.
Yeah.
I'm not good at either of them, but I'm getting it.
I love it.
There you go.
Question number 3. You work with elite athletes. We know that. But what's the one sport or physical activity you personally suck at but wish you didn't?
Let's go back to surfing. Right? I love being in the ocean, but I came to that sport later in life, right?
Yeah.
It's one of those things. You take golf, tennis, swimming. You learn those early. You have those patterns. I would love to be better at surfing.
Well, Terry, I think you're better than somebody at surfing. There you go.
No, I'm not. I tell people go, I like surfing. I'm not a surfer. And people that understand surfing understand that statement. So like this weekend, I'm going to see you, Mike, at the seminar. And on Saturday, all these guys are going surfing at 7:30. I'm not bringing my board because I'm not a surfer. I like surfing, but I'm not a surfer. And I'm going to go in the water with these guys. I go, I'm not going to compete for waves. And no, I like to go out when a few guys in the water. I go out during the week. But I'm not a surfer. I like surfing.
Okay, back to rapid fire questions. Okay, number 4, if you could ever only listen to one song for the rest of your life,
Ooh.
what song would that be?
It's going to be a Tool song.
Ooh.
And I got to put like Lateralis or Parabola.
Love it, man.
I'm a Tool. I love the Tool.
Love it. So, last question, and Dr. Mike Rintala, you have been pretty serious throughout this whole program. What makes you laugh?
I mean, I love comedians. Name a good comedian, and
you name a good comedian.
I mean, everybody from like Bill Burr, Will Ferrell, Conan O'Brien.
Yeah, oh yeah,
those guys,
hilarious.
Yeah,
guys.
I love them.
Sebastian Maniscalco.
Yes.
Right.
Yes.
Right.
He's the Italian guy.
Oh
right?
yeah. He makes fun of everything.
Have you listened to Brad Williams?
No.
He's the dwarf.
Oh God.
I haven't listened.
He is funny.
He's hilarious.
Yep.
Yeah.
Dr. Mike Rintala, thank you so much for imparting such fantastic knowledge. I really, really appreciate the practical approach that you applied to us that we can actually start today. So thank you for all that breathing and breathwork concept.
Awesome.
Thanks.
Thank you guys for having me on and letting me talk about this. And Terry, I'll see you this weekend.
You will. All right, brother. Take care, man.
Thanks.
Thank you.
Okay.
Thank you for listening to today's episode of the Cracking Backs podcast. We hope you enjoyed it. Make sure you follow us on Instagram at Cracking Backs Podcast. Catch new episodes every Monday. See you next time.